Good morning, everyone. Might as well get started here. Thank you. I'm George Kikano. I'm Vice Dean for Community Health for the School of Medicine. I'd like to welcome everyone to the second Ohio Health Data Symposium. I'm pleased to co-host again this year's symposium along with Dr. Ted Wilmslow, who's the Director of Ohio Department of Health. Thanks, Ted, for driving this morning. Welcome back, everyone who was here last year, and welcome. We have a number of new attendees who will be joining us. This year's symposium is co-hosted by the School of Medicine, obviously, at Case Western Reserve University and the Ohio Department of Health. I'd like to have a special thanks for Dean Davis for supporting this program, as well as many staff and faculty who spent hours working on this, mostly Dr. Siran Kurokian, Dr. Amy Shan, and B.D. Littman. Thank you for all your work. It's been quite a year. Last year, this was an idea. We put the first symposium back in August. The focus at that point was more data stewardship and public health. Just in the past 7 or 8 months, actually, we went international with this symposium. We have guests from Taiwan who flew over 7,000 miles from the Taipei Medical University to be with us. Yes, I got a chance to visit Taiwan back in December this past year. It's exactly like Ohio. 7 medical school, 23,000 people. Different weather. The difference is they actually had meaningful healthcare reform back in 1996. They implemented a national health insurance program capturing 99.9% are insured with the one large database. So these folks from Taiwan are going to be sharing their experience, how to use large databases for the past 15 years. They published, they're so way ahead of using this data. Now, this whole data is called big data now. When it comes to healthcare, big data is not big, but is actually massive. If you do the math on this, it's estimated now as of 2 years ago that healthcare big data is 150 exabytes. Please don't ask me how many zeros this is, but it's something big. It's 150. The other way to look at it is that if you were to do gene sequencing on every human being in the world, put them in an iCloud on some server, you end up with less than 5 exabytes. Healthcare data is 150. The cost for healthcare data in the public health sector is estimated to be at $9 billion for the public health, and for healthcare in general, $300 billion. So we're into something here, guys. Now, I still have not figured out how to use the big data for patient care, but obviously, there's been talk about how to use the data for research. Things are going to change. And one hypothesis would be that the big data is going to be generating research questions for us that we have not thought of before. If you see what David Kelber, Explorers, or others, we're going to shorten the time. We'll be able to access data on populations. Thousands and thousands of patients can be done in a matter of days or weeks. Today's program is going to focus more on public health and health information exchange, otherwise called as HIE, and we have some experts from Kentucky, from Columbus, who's going to share their experience with HIE. Unfortunately, there are no national standards now about how to use them, how do you apply them for patient care. I still have not figured them out. The American Medical Association just 2 weeks ago got a letter signed by 200 organized medicine groups in the US. They sent a letter to HHS, figure out, please give us some national standards, some interoperability. How do you use HIEs for the benefits of mostly patient care, secondary research? So we're going to be hearing a lot about HIEs in the next year or two. In keeping up with media, data, and social stuff, for this meeting, I think this is the first time we've done this here. We've established a Twitter account for this conference. So as the speakers, please send your question, follow us on Twitter. There's a hashtag here that Amanda had put together. So please, if you have tweet accounts, follow us and tweet throughout the day. And at this point, it's my pleasure to introduce Dean Davis, my boss. Dean Davis, the Dean of the School of Medicine at Case, has been very supportive for all our community initiative. Dean Davis also the Vice President for Medical Affairs for the Case Western Reserve University. Pam, thank you.
Well, good morning. Thank you, George, and thank you all for coming today. Last year when we gathered here, I learned a lot about how fast data are accumulating. So I can tell you now that since then, 2.5 quintillion bytes of data created every day. I know a quintillion is one with 18 zeros after it, times 365, has accumulated since we last talked. This is stunning and staggering, and the question is really, what do we do with it? Steve Jobs once said, technology is nothing. What's important is that you have faith in people, that they're basically good and smart, and if you give them tools, they'll do wonderful things with them. And I think that this concept is what brings us here today. We do have wonderful tools to talk about. Health information exchanges and an assembly of brilliant experts from academia, healthcare, medical science, information technology, community advocacy, public health, and more to discuss how we can apply big data and these new tools to improve human health. I'd like to extend a special thanks to our symposium co-sponsor this year, the Ohio Department of Health. Thank you very much. And to thank its director and our event co-host, Dr. Ted Wimslow, for his leadership and support in this area. Thank you, Ted. I'd also like to acknowledge the work of our planning committee, led by co-chairs Amy Schoen and Andrew Wapner, and supported by James Coates, Brian Fowler, Yifeng Wan Glavin, Sarun Karukian, and Elizabeth Littman. Thank you for putting together what I think your presence here indicates is a great program. And I'd like to recognize our special guests from Taipei Medical University in Taiwan, who have traveled across the world to add their global perspective to the symposium this year. These experts will play a prominent role in our symposium today, and I'm particularly happy to acknowledge Dr. Cho Hong Yi, who is Vice President of Taipei Medical University and Dean of its College of Public Health and Nutrition. Thank you so much for coming today and for bringing your team. We are fortunate to have their knowledge because Taiwan has been developing a rich repository of health data over the past 20 years from across Taiwan, which has a population, as George said, of 23 million people. And Case Western Reserve is delighted to be exploring collaborative opportunities with Taipei Medical Universities to learn from their expertise and in health information and to partner in research by tapping into this robust pool of health data. Thank you all for being with us and for sharing your expertise. Throughout this symposium, we hope to find innovative ways to remove barriers and connect the dots between technology, research, and healthcare. Because when we connect these dots, we have an opportunity to move medicine forward and improve lives. As the largest medical research institute in Ohio and 16th in the nation, Case Western Reserve School of Medicine recognizes its responsibility to drive some of this dialogue in the state. In May, when the school was asked to lead the Ohio Clinical Trials Collaborative, a collaboration among CWRU, Ohio State, and the University of Cincinnati that opens up statewide pools of patients for clinical trials research, in which Governor Kasich hopes will create jobs by making Ohio an attractive place to conduct clinical trials and bring patients quicker access to innovative treatments, we recognized our need to step up and assist in the state in this important initiative. The school is also home to one of Ohio's regional extension center, we call them the RECs, which are charged with helping local physicians adopt electronic health records. As of last fall, Ohio was 6th in the nation in the number of providers registered to participate in one of the CMS Meaningful Use Incentive programs. Wow. And our rec here at the School of Medicine exceeded its goal and signed up 1,550 priority primary care physicians in Ohio. And we lead the state in physicians achieving meaningful use. So I think that's a real tribute to Joe Peter and his team in getting the word out to our primary care docs. According to the U.S. Department of Health and Human Services, nationally, more than half of doctors and 80% of hospitals have switched to electronic records, and in Ohio, 61% of docs and 94% of hospitals have gone electronic, and the numbers continue to rise each month. Today, we'll be hearing about best practices locally and from around the world in health information exchanges that apply the data from these records to advance research in public health. Now, many see these HIEs as the critical tool that will transform our volume-based health system into a system based on value. And although it may not be a panacea for all the challenges in our system, this is certainly a historic time for medicine. Never before have we had an opportunity for instantaneous access to data from thousands of patients, or a reporting system that can track infectious disease in the course of hours rather than months. Nor have we had the ability to measure quickly and monitor outcomes in an entire population to see what's working and what's not, and to apply this information to improve health. By opening our eyes and ears to success stories from around the world, we may find global solutions to our local challenges. So I hope the information you'll hear will promote collaboration between and among our organizations and integrate data that in the end will help us all provide better, more affordable, and more efficient patient-focused care for the good of our patients, our region, and beyond. So thank you all for your participation in this symposium and the role that each of you is playing in advancing human health. So now it's my pleasure to turn the program over to Dr. Theodore E. Winslow, Director of the Ohio Department of Health, our event co-sponsor. Dr. Winslow has worked as a family physician, administrator, and educator for more than 30 years. And as Director of the Ohio Department of Health, he is charged with coordinating Ohio's 125 local health departments and public and private health partners to improve the health and wellness of Ohio's 11.5 million residents. His career is punctuated by leadership roles to advance quality patient care and include multiple distinguished service awards for his commitment to the profession and to his patients. Please welcome Dr. Winslow.
Well, thank you very much for the invitation to be here and the opportunity to co-host this conference. The reason that we're co-hosting this is that we feel it's that important that public health be involved in these type activities that are occurring around the state, that we decided that we should step up and actually, if we could, perhaps take a leadership role in some of the connectedness, some of the coordination of care that's happening around the state, and have a bigger interface with clinical medicine than perhaps public health has been seen as playing in the past. So I really appreciate the opportunity to be here today. I appreciate the kind introduction and want to introduce the Ohio Department of Health as a full partner in this activity to go statewide in our ability to exchange information. If you look back at why we're doing all these things, though, and from time to time it's important to do that, we want to make sure we've got our eye on the right prize and we've got ourselves focused on what we're really here for. Because in the end, the electronic medical record and health information exchange activities are only means to an end. And the end that we're trying to achieve is that optimal health and wellness for our population at every stage of their life. And we've lost that over recent years. In fact, it's said that our current generation may be the first one that does not have a longer lifespan than the current generation because of many of the problems that we're facing with obesity, with smoking still not under control, with addictive substances that people are using other than that. The many, many ills of society are creating problems, and we're not moving in the direction we'd like to as a society. And so I'm very interested in hearing what the individuals from Taipei have as an approach to how they're trying to get this animal under some type of control. But at least in the United States, we've come to some agreement, and the Surgeon General released this last year, an organized approach from 17 major organizations on how they want to see if we can't perhaps focus on the pipeline differently and do something to impact the flow of individuals with chronic diseases and see if we can't perhaps halt that or at least stymie that flow. If we don't, we're going to have an unaffordable and impossible task facing us as our aging population comes to the fore, one that we probably will be struggling to try to deal with. If you look at the Ohio Department of Health, I have over 120 departments that we work with on a daily basis. They're all important to me, so if they raise their hand and say, who do I like best, I have to say just all of them equally. But from time to time, we, like you, have to pick a few priorities and say, boy, if we don't do anything, we got to be sure we at least get these things done. And during our last strategic planning process, and many of you were involved in our state health improvement plan that was developed, we devised 4 areas of focus that we're going to maintain focus on during this 2-year period that we're in. On the top left is expand patient-centered medical homes across Ohio, which has a beautiful interface with what you're all here today for and what you're about. And that's putting together a coordinated plan and method of providing health care to all Ohioans. Curbing tobacco use has still escaped us as a state as a goal that we've had. We're 11th worst in the nation as far as our rate of smoking at about 25% of our adults, and we think that's intolerable, and we'll be taking focused action on that. Reducing obesity, and today I have Dr. Andy Wapner, I think, with me here, who's running a lot of our efforts to address obesity. Lately, recognized focus on childhood obesity as a special area of focus if we're going to get up that pipeline and try to have the impact we need to. And then decreasing infant mortality, of course, is a huge effort, and Cleveland is no stranger to efforts at getting at that in the population that surrounds them. Much that's been done in this community will be used around the state as models that we can use to try to have a positive impact. And I have Ann Harnish with me here today, and Ann's somewhere in the room there. So Ann's leading our efforts at the Ohio Department of Health to address and combat infant mortality. So we've got the right people in the room, we've got the right people focused on these problems, but we're going to need a lot of your help, because if you look at all these areas that we're focused on, they are impacted in a positive way by having a better understanding of what's going on, where it's happening, who the providers are who are engaged in this, and what they're doing that's effective and working well and what's not working well. That information helps drive scarce resources to the correct sites so that we can accomplish the most we can with what we have available to us today. So we're looking forward to, with you, devising a very effective way of being able to exchange information, not just to have information, but to use it, right? Because we've got data. I've got data all over the place in my organization. It's how you use it that's going to determine our success for the future. Well, many of you know that I'm, I think, destined and probably designated as the official cheerleader of patient-centered medical homes statewide. So I always have to put that into any of my slides because I think we have a fundamental problem. And yesterday I was in House hearings on health, and they were focused very much on opiates and mental health disorders and a number of other illnesses and ills in society. And I had to keep bringing them back to the fact that we don't have a very good system of care that keeps these things from happening. And so I said, you can continue to put resources towards problems and have focused programs for those problems, but that's never going to get past just focused on that problem and not have another thing arise without us having a coordinated system where we actually have the entire health care of our whole population in focus at one time so that we can make good decisions that have a positive impact on our whole population. This would be, to me, the foundational unit that we need to build upon if we're going to ever move forward with bundled reimbursement programs or at some point ACOs or others. They've got to build on something that's got good information, good exchange, good coordination, but a personal relationship has to be underneath that. We can't remove the personal relationships and expect that we'll be successful. So these core components that are built into patient-centered medical home development and programming seem easy, but we find with clinicians when we work through that in their practice that they're difficult sometimes because they're age-old concepts that need to be modernized, and we need to use modern tools to get there. And the modern tool we have is the E.M.R, especially one with a registry, especially one with an actionable registry, especially if it's connected to someone other than yourself. So this is what we're trying to carry forward if we can. And so I have fun with my mental health colleagues, and I would talk to individuals from the nursing home industry and other industries, and they're all asking, how can we be a part of this movement in healthcare? And I tell them, be connected. And we ran into that with school health programs. So, I think it's a great idea to put programs in place in school if they're connected to something beyond the school. If they're only in the school, of the school, and by the school, that's not going to help us in a system to address our needs that we have. And look at all the focus we have on youth and the importance in obesity and smoking and tobacco use and other activities or lack of activity that we're dealing with in the school age kids that we're raising. It's our next future generations of healthcare users and hopefully health experiencers. So on the integrated throughout this is the electronic medical record and our ability to use it effectively to modernize these principles so that they work effectively for our current population needs. Well, the patient-centered medical home, if that's home to all the information, all the data, all the knowledge that exists about the health of an individual, it's got to be connected to all types of resources all around it in the medical neighborhood. And it has to be a push-pull relationship where everyone knows what the other's doing, everyone understands what the other knows about the patient, but the total repository in the patient-centered medical home ensures that for the patient as their first point of contact, the whole picture is in focus when decisions are made with their personal primary care clinician that they're working with. We're working hard across the state of Ohio to make this available to everyone in the state of Ohio. And so yesterday, as we were talking about what happens to people coming out of prisons and the difficulty they have with many of them with many chronic illnesses as they put them out into the community and have nowhere to connect them, we want to not have that happen. We need to have them connected before, during, and after those type of, unfortunately, incarceration experiences with something that transcends the episodic interfaces that they have with healthcare providers in different systems. Similarly, for the whole population in Ohio, we'd like to have this connectedness so that wherever they go in the state and in the country, we have the ability to have a clear understanding of what their situation and circumstance is so we can make good decisions about their health, and more importantly, so they can make good decisions about their health, because patient empowerment is probably the greatest component that comes with the electronic medical record. The patient now has access to their information. They have the ability to look and track and know about their health and learn more about their health through that connectedness that they never had when we had paper records in our offices. And so engaging patients is the huge benefit I think that we bring to the table with the electronic capability that's brought forward. Well, my responsibility as Director of Health is to take care of 11.5 million people. So that's a big one, and that's hard to do, and especially hard to do if I don't partner with a lot of people all over the state that share our understanding and interest in population health. But to do this effectively, we in public health can't do it alone, and people in clinical medicine who traditionally have had more of a focus on illness care and not as much on health care, but that's changing, I understand that, need to come together. And we need to work together if we're going to cover the broad expanse of needs of patients that relate to their optimal health and well-being that we're trying to achieve. These are linked in a way, and at this meeting we're very closely linked, and I'm happy to see it, that we have a lot of people that are public health employed. We have a lot of people that are private health system employed. We've got a number of people that are working in a variety of different settings who are coming together saying, probably if all of us work together, we'll be successful in achieving the goal we have of total health for Ohio. You may know, as we look at state health rankings, Ohio ranks 35th in the last comparative review that United Health Foundation put together. Well, it's kind of good news because last year was 36th, right? So I think we're moving in a direction, but I've got to tell you, at the rate we're going, I'm going to be dead before we get to a good place. So we've got to propel ourselves just a little faster. So I was really happy to hear when ONC recognized Ohio as the lead state for moving forward with technology, and we're also a lead state in a few other areas. But to go back to this integration imperative, IOM recognized this last year, and last March released their report and their book on the importance of integrating public health and primary care if we're going to optimize population health. And they talked about different stages of integration that occur in various states and various communities, but I'm encouraging all of you in your communities to hug your health commissioner and work with them very closely as you try to move your system forward together. They have a lot to offer you. You have a lot to offer them. Together, we'll be successful. Alone, we don't have the resources, capability, or expertise to get the job done. And information exchange is going to be critical for that success to happen. So in public health, we worry about things like environmental factors that affect health. We focus on social determinants of health. Employment rates are important to us. Education levels are important. Safety in communities are important. And repeatedly, when we only throw medical interventions, clinical interventions at patients, we fall short in achieving our goals. So over and over and over with infant mortality, we've struggled with this, saying, how can it be that we are doing so poorly in the shadows of some of the greatest institutions in America and having such bad outcomes? And that's because we have to keep going upstream to preconceptual time. We need to go further upstream into social determinants of health, or we're not going to have the impact we're looking to have. Coming together is going to get us where we're trying to go. Disease surveillance and epidemiology are foundational components of all public health. Immunization is what everybody thinks of. So when I talk to people, typically at the AMA, they go, oh, you guys take care of immunizations, and that's all we need to know about public health. So, we have a conversation constantly with my clinical partners that don't work with us more closely. Health data is what we're very rich in. We've got information. Vital statistics would probably be the easiest example for you to know about all our birth records and our death records, but it's the information that's contained in those that's so rich and needs to be mined further. Regulatory functions, of course, we're out there looking at nursing homes, making sure they're doing good jobs. We're looking at cardiac cath labs. I get in your hospitals for maternity units and newborn nurseries, and we have a number of other regulatory functions to make sure people are compliant with what's expected of them from the different payers that hold them accountable. But policy might be the biggest area of influence that we can have, and you'll be discussing policy issues all through your day. And a lot of it has to do with privacy, and maintaining privacy and protection of patient information that we'll be struggling with as we look at how and the best way to exchange information, but still protect individuals' privacy. And I'll be real interested to hear what my international neighbors will be saying about how that's been addressed in their systems that they have. What I'm trying to do at the state level is integrate health into all policy decisions that are made. So yesterday my meeting was with the Board of Regents, and I worked with the Chancellor through a number of different decisions they're making in higher education, mostly related to curriculum, because I want to be sure we're training people to do the stuff that I need 5 and 10 years from now. I do not want to train for the past. We want to train for the future. So for any of you who have fun with shotgunning, you're not aiming at the target, you aim at where it's going to be, not where it is now. So all of you are focused on aiming at a target that's in the future somewhere, and you've got to think that way and prepare a workforce for that type of activity in the future, that they'll be able to do the things that we need them to do to move our exchange efforts forward. Well, exciting news for Ohio is that we've been selected as one of 16 states by CMMI, the Centers for Medicare and Medicaid Innovation, to develop a statewide plan that will get at the triple aim, which is improving patient experience of care, improving health of populations, and reducing the per capita cost of health care. In the line that's the best care for the whole population at the lowest cost is their goal. And I think everyone agrees that's a great goal, but no one knows exactly how to do that. And so Ohio's been selected initially for the planning section of this grant. $3 million has come to Ohio, and we have 6 months to put together a game plan, a change plan, a transformation plan for the entire state of Ohio. It's got to have 2 components to it. One is a service delivery model. How would we want to deliver care statewide that would change all of healthcare in the state? For us, that'll be the patient-centered medical home model of care available to all Ohioans. The second component is how you're going to pay for it. So that has to do with payment reform, and for us, we're working with bundled reimbursement. We're looking at other methodologies for changing the way we pay so that we're paying for value instead of volume, moving away from the fee-for-service system into an outcomes focus. How do you get that done? You can't without an exchange of information that facilitates the capability to make all of that happen. You can't coordinate care without a coordinating tool. We can't get at reimbursement reform and better outcomes without a method of tracking what we're doing and successfully deciding how to eliminate that 30% waste that Institute of Medicine says is out there in healthcare. I believe there is 30% out there. Everyone will argue where the waste is, and we see the fingers pointing all those directions. So it's up to us to define where is the waste. You all got one of the Choosing Wisely grants right here in Cleveland. What an opportunity to help us make good decisions based on sound evidence about where we should be putting our resources to get the best return on that investment and where we can stop wasting money. So if all of primary care for the national budget consumes 5 to 6% of the $2.5 trillion spent, and if I can address the 30% waste along with you with Choosing Wisely and other activities, if we just recapture 1 or 2%, drop that into the PCMH primary care activities we're doing, that's a boon to primary care, but it's a very small shift in total resources nationally and at state level that's happening. Well, our real goal in putting together our planning grant for implementation of a statewide change is to get the testing grant, ultimately, the ability to actually do the implementation, which allows up to $60 million to be used for that cause to go statewide with PCMH and a new reimbursement plan to pay for value rather than volume over a 42-month period of time. We're in a very good position to do that. Cincinnati's been very helpful, and I know Craig Brammer's here in the audience somewhere, and they're leading the charge on showing how this could be done with that Center for Medicare and Medicaid Innovations Comprehensive Primary Care Initiative. Don't we have a lot of words that we use now? I didn't have to worry about these things when I was in practice, but we try to keep all these different things straight. But CPCI is a wonderful experience that Ohio's involved with as one of 7 states in the nation selected, and they all wanted it. So to be selected as one of 7 that were pulled into that initial demonstration with Medicare and Medicaid was huge for Ohio. Now we want to build on the success that's been shown in some of the regional efforts that are moving forward. If you want to know more about the Patient-Centered Medical Home, if you want to know about our Ohio Patient-Centered Primary Care Collaborative we put together, where over 600 corporations, individuals, agencies are talking to each other on a regular basis, you can go to our website at Ohio Department of Health, click on Patient-Centered Medical Home, and it'll give you a map of the state. You'll see where the patient-centered medical homes are, but you'll also see how you can sign up to be a part of the Ohio Patient-Centered Primary Care Collaborative. It's free. And we've got more and more people joining every day, and they're working from around the state to help us move the state to a better place. Well, if you don't like uncertainty, and if you're afraid of the unknown, you're going to be really in a bad place right now, because there's a lot of uncertainty facing us. There's a lot of danger ahead, but that's what makes this an adventure, and I'm really happy to have you as partners in the adventure that we're moving forward with. The Ohio Department of Health is ready to partner fully with you, and I thank you all for being here at this conference. Thank you.
Thank you, Dr. Winslow, for a great remark and to guide today's discussion. I think your connectedness today go pretty far in terms of connection far beyond Columbus, Ohio, Columbus, Cincinnati, and Cleveland, of course, and to halfway around the world. So it's my pleasure to introduce you the featured speaker, Dr. Chu Hong-Yi. And Dr. Chu is a Vice President, Taipei Medical University, Dean of Medical College Public Health and Nutrition, and also he served as the President of Taiwan Public Health Association. Dr. Chu will share with us today the Taiwan National Health Insurance, and as Penn and George mentioned, Taiwan Health Insurance, National Health Insurance Institute, 1995, covered 99.5% of the 23 million Taiwan population, and with a total expenditure of 7% of GPD and 2% of administrative cost. And Dr. Chu is going to share with us the Taiwan National Health Insurance, the Health Information Exchange, as well as how to use the Taiwan National Health Insurance as a base for research. Dr. Chu.
Thank you for Ifan's introduction. It's my honor and very pleased to be here to present the health information exchange content for all of you. And my topic include two content. One is our introduction for our health insurance instance data, and the other is my present over to brief introduce our health exchange cases for all of you. So I'm talk about the opportunity for research and the public health improvement, some experience from Taiwan. And let me brief introduce the Taipei Medical University. Taipei Medical University is a private university and located in the Taipei City, the capital city of the Taiwan. And we is a median university with the 7 college. We have with 7 college, and we have several administrative unit to support the 7 college to carry out their research and their teaching. And we have 3 hospitals, and we have also a long-standing medical mission team for the Africa country in Kingdom of Swaziland and the Saint Thomas Principe. And this is our President, Professor Yan. Before he served as the president of Taipei Medical University, he was the vice dean of City of Hope in California 3 years ago. And this is our the chairman of Dr. Lee. He's also our alumni. He is the dentist. And these 3 hospitals is our affiliate hospital. First is our own hospital located in our university campus, and this is the TMU-CWRU Hospital. He's owned by the Taipei City government, but he's OT is they build the building, and all the facility is owned by the Taipei Medical University. And the 3rd hospital is owned by our government, the Department of Health, and this called the BOT. He give us the land, and we build up the hospital and own everything. And these 3 hospitals total around 3,000 beds, and all of them have accredited by the Joint Commission International, we call the JCI. And today, the outline of my topic is first is the national health insurance, and the second is e-health and the health information exchange, and the third is the national health insurance research database. And then I show the video for you. It's around 12 minutes.
This is an overview of Taiwan's National Health Insurance Program, which was implemented in 1995 to provide health care for all the residents living in Taiwan. About 23 million people live in Taiwan, and more than 10% of the population is over the age of 65. Adjusted for purchasing power parity, per capita GDP was $35,604 US, and per capita national health expenditures were $2,335 US in 2010. Spending on national health was around 6.6% of GDP. Life expectancy was 76 for males and 82.7 for females. Before the NHI program was created, Taiwan had several social insurance programs, such as labor insurance, government employee insurance, and farmers insurance, that provided medical care to specific groups. But only 57% of the population was covered by these insurance plans. In 1995, the government consolidated the medical components of these social insurance programs and launched a national health insurance program to provide health care to Taiwan citizens and foreign workers. After the NHI program has been in implementation for 16 years to better satisfy the demands of the population and accommodate the practical requirements of the program, the government has enacted the 2nd generation NHI, signifying an important reform of the 1st generation. The 2nd generation NHI was implemented in 2013. Here are some of the main characteristics of Taiwan's insurance program. National health insurance is a compulsory program. All residents must enroll. The BNHI is the only agency authorized to administer the program. The program is mainly financed by basic and supplementary premiums that are contributed to by the employer, employee, and government. Those covered under the program receive services defined in a comprehensive benefits package, but they need to pay a copayment when seeking medical care. It is optional for healthcare providers to participate in the program, yet about 92% of providers nationwide have signed contracts with the BNHI. Providers are reimbursed according to Plural payment schemes under a global budget. The premiums and copayments of the disadvantaged are subsidized by the government. The Bureau collects premiums from the insured, their employers, and the government. The insured pay copayments when using medical services, and providers in turn file claims with the Bureau to have their medical costs reimbursed. Funding for the program comes primarily from insurance premiums, including basic and supplementary premiums. Basic premiums are calculated based on monthly salaries. Supplementary premiums are imposed on non-payroll incomes. NHI premium rates are determined on an actuarial basis. Meanwhile, the National Health Insurance Supervisory Board is responsible for the review and approval of important financial initiatives such as insurance premium rates, scope of benefits, and the growth rate of the global budget for the following year. NHI's finances are evaluated based on the principle of pay-as-you-go to ensure its financial soundness. The insured are classified into 6 categories and subject to different premium calculation bases and contribution shares depending on the category they belong to. Most salaried employees belong to Category 1. They have to pay 30% of their premiums. Their employers pay 60%, and the government the remaining 10%. The government subsidizes 100% of the premium for low-income households, veterans, and conscripted military personnel. To fulfill the ideal of universal coverage, prisoners are now also covered, and the premium is paid by the government. In addition to the basic premium, a supplementary premium will be collected under the second-generation NHI. The insured will be charged a supplementary premium of 2% on other incomes received, including large bonuses, stock dividends, part-time income, interest income, income from professional practice, and rental income. The NHI program provides a comprehensive package of benefits that covers inpatient care, outpatient care, drugs, dental services, traditional Chinese medicine, daycare for the mentally ill, and home nursing care. Expensive medical services such as MRI, hemodialysis, and organ transplants are all covered if medically necessary. When visiting medical facilities, the insured must pay small copayments, which are $1.70 for clinics and district hospitals, $8 for regional hospitals, and $12 for medical centers. The copayment is partially waived with a referral. To ensure that people who really need health care do not lose access because of the cost-sharing mechanism, individuals who meet certain conditions are exempt from making copayments. If the insured requires stays in a hospital, they will be charged a fixed coinsurance that varies according to the length of their stay. However, this copayment is capped at around $1,033 per hospital stay and $1,733 for the same disease in a single year, the latter being 1/10 of per capita income. The Bureau of National Health Insurance has used a health insurance card with an embedded IC since January 1st, 2004. The card contains records of a patient's last 6 visits, drug prescriptions, allergies, and consent to donating his or her organs. Among its many merits, it can be used to monitor high utilization patients and detect fraud by analyzing data uploaded to the Bureau. It can also help track down communicable disease suspects in major epidemic outbreaks. In the future, cloud computing technology will be applied to give the card additional and more powerful functions. in order to provide more comprehensive healthcare to the public, the BNHI adopts multiple payment methods to reimburse healthcare providers for medical services. The Bureau initially reimbursed providers based mainly on a fee-for-service basis. Then, to better control medical expenditures, the Bureau implemented a case payment for simple and standardized procedures in 1997 and completed a global budget payment system in 2002. To further standardize the reimbursement of medical services, the Bureau initiated a resource-based relative value scale in 2004 and a Taiwanese version of DRGs in 2010. In addition, a capitation was implemented in 2011 on a trial basis. The average utilization rate of NHI outpatient services in 2011 was 15.1 visits per person per year. Those visits include visits for dental service and traditional Chinese medicine. For inpatient care, the average utilization rate was 13.8 admissions per 100 persons per year. The number of outpatient visits is substantially higher than that seen in many OECD countries. But on the positive side, this testifies to the convenience of visiting a doctor in Taiwan, for which there are practically no financial barriers. NHI premiums are calculated based on regular salary income. In recent years, however, salary income has steadily declined as a percentage of national income, leading to premium growth lagging behind income growth and funding shortfalls. The introduction of the supplementary premium on incomes other than regular payroll is expected to alleviate the perennial financial problems. For people who are less fortunate, the government provides several types of assistance to make sure they have the access to medical services, such as the premium subsidies, financial assistance for the near poor, and medical assistance for the disadvantaged. There are more than 19,000 healthcare institutions contracted with the program to provide medical services to the insured. The insured can receive medical services either by appointment or by simply walking into a healthcare institution. Services are usually provided in a timely way, and waiting time is negligible. Beyond that, the Bureau initiated an integrated delivery system plan to improve healthcare on offshore islands and in mountainous areas by encouraging hospitals to dispatch doctors to these areas. This plan provides healthcare to 48 outlying islands and mountainous areas and serves some 400,000 people per year. One of the core values of Taiwan's health insurance is breaking down barriers to healthcare for every citizen by having the wealthy subsidize the poor and the healthy subsidize the unhealthy. This explains why the NHI can even cover patients with hemophilia who spend 123.8 times as much as the average. The NHI program has earned a good reputation among Taiwan's people and is generally considered to be one of Taiwan's most popular public programs. The public satisfaction rate has improved from 39% in 1995, the NHI program's first year, to 61% in its second year, and around 80% more recently. Since its implementation, the National Health Insurance Program has resulted in a continuous and steady improvement in the quality of medical services in Taiwan, in part by bringing a great number of new drugs and medical technologies under its scope. Life expectancy has increased to 82.3 years for females and 76 years for males, and the infant mortality rate is 4.2 per thousand. Those numbers place Taiwan on top of many OECD countries in terms of the performance of the healthcare system. New drugs and state-of-the-art technologies covered by the insurance program have contributed substantially to quality of care. For example, the 5-year survival rates for colorectal cancer, lung cancer, and breast cancer in Taiwan are comparable to those in Australia and the US. Survival rates for patients receiving transplanted organs are close to the US levels. The major achievements of Taiwan's national health insurance system include achieving universal coverage and providing easy access to medical care for every citizen at an affordable cost. Public satisfaction with the program is also high, and medical quality is up to standard. Under the second-generation NHI program, a linking mechanism between revenues and expenditures is expected to make the health insurance program more financially stable. The supplementary premium will see to it that those who are better able to pay contribute more to premium revenues. Moreover, by strengthening medical information sharing and encouraging participation from society in the NHI policymaking, the quality of medical care will be improved and the NHI program can be sustained. We welcome you to visit our website at www.nhi.gov.tw for updated information. Thank you for your kind attention. We hope you enjoyed today's presentation.
Okay, let me talk about the second topic is the e-health and the health information exchange. And e-health for Taiwan is a tool based on the information and the communication technology used to assist and enhance the prevention, diagnosis, treatment, and monitor the health and the lifestyle. And HIE, we mean the health information exchange is a specific field in the e-health. And how can benefit from the HIE? We can describe from the patient side, the provider side, and the payment side. For patient, the benefit might be the person choice and the healthcare management. For provider, he can reduce his administrative work and the decision making and the paperless. And for the payer, he can use to monitor the utilization and the survey the disease prevalence and the cost containment, quality improvement, and the patient safety. And as you see in the video, the HIE application in Taiwan, first we call the smart card, the National Health Insurance Card. And the second is the public disclosure of health information. And the third is we established the electronic medical record exchange center, we call it EEC. And for mass card, his initial form is the paper card, and only can register the 6 visits for the patient. And if you roll out the paper, they can renew the new one. And the 2004, we start the smart card in this form. And a smart card function just described in the video, the prescription and the examining record, and the treatment record, and the catastrophic illness record, and the organ donation, and the NHI care auditing mechanism, and the final is timely information for disease surveillance. And for the public disclosure of health information, the goal is to assist the people to evaluate the medical care facility and his previous history of medical care provided to patient. And the method is to obtain the information by the brochure and the internet. And the indicator we expand from the 3 popular disease to the now is 6 items currently. And our data source is from the National Health Research ID Service reimbursement claim, and the information is renewed quarterly. So the rationale for our HIE is to obtain the medical care quality performance for medical care facility, we call the provider. And the second, we compare the provider performance and can facilitate us the useful tool to evaluate the medical care quality. And the third, each year we publish in the MCQ performance, and then we can promote the provider to compete their quality and further to improve their quality. And also we can let the demand of medical care facility to maintain their standard of the MCQ at the very least. And the last, we can help to confirm the area for the provider to figure out what the area they are needed to work out. And the diabetes, I use the diabetes as the example. We are 4 areas to be sure. First is to get to know, and the method to use, and the result to search, and the search for the individual medical facility. This is our website. This is the public information disclosure, and this area is the quality indicator for the medical facility. So our resident can search from here and choose which provider he want to be. And these 6 disease-based quality indicator. Now it's the diabetes, something like, and the near ankle, and the ESR, the hydroxylation. And the other is get to know and information about the DM, and the hyperlink for DM, any website, and the method how to use, and further explanation for the provider and the quality indicator. And the last is the result of research, and the indicator of illustration, and for example, we use the HbA1c as the example for the control quality for diabetes patient. And then this is the search for individual medical facility. And we also established the E.M.R, Exchange Center. And our Department of Health introduced the E.M.R system right now, but the facility just stay up. So we need to provide the incentive to ask the provider to upload their medical data in this center. And the data exchange is part of hospital subsidized scheme to promote use the E.M.R in the hospital. So the aim is to integrate the patient health information and to avoid the redundant medical test, prescription, and the insurance claim. So this is the figure to show the patient use the IC card, go to the laboratory or any clinical, and then the data will upload into the E.M.R server. And then if next time he go to the hospital, and the hospital request the patient any medical record, and then they can extract the data from the National E.M.R Exchange Center, and then the previous medical data will be download to this hospital, and then we can preview all the history of the medical prescription and the diagnosis. So, but however, the HIE limitation will have the 3 major limitations. First, the information accuracy. I think this is the same phenomenon in the state. And the second is the personal privacy versus the public goal. We still to debate and need to some negotiation. And the third is the financial driven. And the future for HIE development might be focusing on the patient education, and we have to modify our regulation, and we have to put more incentive for the provider. And the third part of my topic is the National Health Insurance Resource Data. To the 2012, the peer-reviewed journal paper using Taiwan National Health Insurance paper, it's about published near the 1,000 paper. And you can see the paper quality not bad. About half the impact factor is a range greater than the 3. And the majority of the paper located in the ranking in each category around below the 40%. And mostly located in the impact factor around 3 to 5. But recently, because Taiwan researcher familiar with the data quality and how to use the data, so last year we have the 1 paper published in the JAMA. So the big data also can publish in a very high top journal. And in 2004, this paper located in the 30 SCI field. But to the 2009, the SCI field expanded to 60 area. And this figure shows some area like biomedical science, clinical medicine, infectious disease, something like that. So every more and more scientific field, they accept using the big data to publish the paper. And for TMU, the publication number divided by the total number in Taiwan, the number percentage around 30%. And I say that 1/3 of the paper in Taiwan using the NHI data was published by the Taipei Medical University. And we are very happy to have the cooperation with the case. So we established the TMU and the Case Western Data Center. So in the afternoon section, we are two topics to be sure. One is the epilepsy, the other is the prostate cancer. And this center will explore the joint proposal interest into finding opportunity and support the joint publication. And we cooperate with the joint data, the NHI and the clinical lab and the long-term care data to global-based decision making. So this is my topic content, and I welcome your question. Thank you.
If you don't mind, maybe you can take 1 or 2 questions.
Yeah, okay.
It sounds to me like this is the Affordable Care Act version 2.0.
Thank you very much. That's very exciting, and we really appreciate the opportunity to hear of the accomplishments. I had a question. In Ohio, a large part of the state budget for health goes into paying for care in the nursing home. So not just, say, the nursing care, but also the room and board, the actual care of the patient. That's a substantial portion of the Medicaid budget. Is that addressed at all in Taiwan, or does Taiwan not have nursing homes?
Taiwan has nursing home, but most of them are private section. So, however, you can see from the video, our national health insurance also pay the national fee. But we maybe next year we are start from to the long-term care insurance. Now we are a little hesitant to when is the D-Day to start because the financial balance. So we still figure out some basic data to calculate the reimbursed fee and the premium fee. So this is why we here to cooperate with the Ohio and especially for the Case Western, because you are very good experience to join the Medicaid and Medicaid data and we hope to learn something from here and to build up our new model for the long-term care system for the nursing home, the daycare, something like that. Thank you.
Many countries with national healthcare systems also have private systems that the more wealthy residents subscribe to, in addition to the national health insurance. Is that true in Taiwan as well?
Yeah, this is very important. We see the how to, but the relative percentage is still to calculate. But in Taiwan, for our political situation, every year we have to elect. So the government was very hesitant to ask the private section to pay more money. It's very struggle and very suffering in this current status. But so we quite need to use the evidence base, more scientific data to show to our government. Yeah. So you can see in Taiwan the total health expenditure only account for the 6% for our GDP. Based on this cost, we cannot afford for the long-term care insurance. Is right. So why I say we are hesitant to start. The D-Day cannot be decided because still now we did not have the solution to balance the financial. Yeah. Thank you.
Thank you much.
Yeah. Thank you.
Yep. We have a lot to learn. I mean, 7% of GDP, better healthcare indicators, 99% coverage. I mean, that's impressive. Thank you. It's my pleasure to introduce Brian Fowler. Brian is the coordinator of the Office of Information Technology at the Ohio Department of Health. And Brian is going to be coordinating a panelist of 4 talking about HIEs at the national, state, rural, and urban level. So Brian, it's all yours. And just because the way the tables are set, we're going to have the panelists come one by one.
Good morning. So we're going to move from the international perspective to a more local, state, and national perspective on HIEs. As Dr. Kukano said, we're going to have 4 speakers. The idea is that each speaker is going to have about 15 minutes to speak. They each have a PowerPoint, and then at the conclusion of all speakers, we're going to have a panel discussion here at the front. So our first speaker, Craig Brammer, is going to speak about both the national perspective and the local perspective from the Cincinnati area. Craig Brammer leads the Greater Cincinnati Healthcare Transformation Efforts. He is the Chief Executive Officer of the Greater Cincinnati Health Council, the Health Collaborative, and also HealthBridge. And HealthBridge is one of Ohio's HIEs. I'd like to introduce Craig Brammer, and Craig, are you? Come on up. Thank you. Yeah, it's kind of interesting back there. There's drinks and everything. It's kind of neat. Thank you.
Hi, everybody. That's not me. I'm pretty sure. Let's see. I guess this is up to me. Well, good to be here. I'm a Cincinnati boy. I was raised on Skyline Chili. I don't see my slides. Up. Sorry, guys. Is my deck on here, folks? That's not me. Is that me? I'm sorry. All right, let's try this again. I'm a Cincinnati boy. Raised on Skyline, I'm a Bearcat. I bring you greetings from south part of the state. Hooday. Hope you are well. It's good to be here. I'm going to zip through some work. I had a brief adventure outside of my hometown of Cincinnati where I was in Washington, D.C. for the past 3 years. I was at the Office of the National Coordinator for Health IT. I managed about a $260 million innovation fund. My focus was on the intersection of payment and technology policy. It was a great time to be a wonk in D.C. I was in the Supreme Court when Justice Roberts read the final ruling of the health law. I was sitting next to Michelle Bachmann. Neither one of us understood what had just happened. CNN didn't either as I walked past them on the way out. It was great to be in D.C. too and focus on technology and payment, which is the sort of the least controversial part of all the activity going on out of D.C. So you're right in the middle of it, but nobody's shooting at you. So it was a real treat. And they asked me to give you a report from the nation's capital. I actually just flew in from there again last night. I lived right behind that flag, so I walked past this grounds every morning going to work. I feel like an American walking into the HHS building as the flags are flying. So what are we trying to do as a nation, as a state, as a community? Cincinnati, Ohio, and Cleveland is the triple aim, as I mentioned before: better care for individuals, better health for populations, and lower per capita costs. Credit goes to Don Berwick, who was at Institute for Healthcare Improvement and then CMS, as you all know, for a while, who really brought in the lower per capita cost part of this triple aim. You know, it was easy to talk as providers about better care, better health. It's mom and apple pie. But now we have this robust conversation. Whatever your role is in health and healthcare, this is your North Star. The policy framework from DC looks like this. Foundation of technology using meaningful use of electronic health records and health information exchange, upon which we can build improved care delivery systems and innovation, provider feedback, measurement systems, payment reform, ultimately to lead to improved quality and efficiency. So if you see something coming out of DC at the delivery system level, this is in the back of their mind. It fits somewhere in this little triangle. Healthcare transformation at the delivery system level, I distinguish that from the insurance level, which we, of course, are following the exchange. We're not supposed to say exchanges anymore. Health insurance exchanges are now health insurance marketplaces because it's too daggone confusing with the health information exchange conversation we're having. So the marketplaces are well underway. New reports from California are fascinating, and coursework will be happening here in Ohio. But at the delivery system, healthcare transformation at federal level is a two-act play. Wire the system and rethink the way we pay for the system. Step one of the play was high tech. This is $30 billion plus in meaningful use incentives and standing up information exchange functionality across the state, or across the nation, often state by state. It was mentioned before that we don't have standards around HIE. The truth of the matter is we do have standards. It's just that standards are like toothbrushes. Everybody has one. They just don't want to use anybody else's. So as a geeky joke I got from the standards guy at ONC, they think that those kind of jokes are hilarious. Those are some weird people, by the way, the standards guys. So a lot of quality reporting on high tech, and of course folks are familiar with meaningful use. Act 2 in this play is the ACA and the payment reform aspects of the ACA. So Medicare payment policy is frozen rock solid for 30 plus years, and for the first time in history it's thawed. Doesn't mean it's going to be good, doesn't mean it's going to be bad, it just means it's fluid. We don't really know what's going to happen. There's testing all kind of new payment models. Now is the opportunity to test and learn. And the health law gives the secretary authority for the first time in history to actually scale anything that the actuaries demonstrate is effective. So that's a big deal. It's an opportunity, it's not a guarantee. So that's why we're excited about leveraging that opportunity. We have to make it work. So you hear about ACOs, which are awesome consulting opportunities. You hear about medical homes and bundled payments, et cetera. You'll hear more and more about that. So the aim here is transition from fee-for-service to value-based purchasing. I was finally asked to give a report from Southwest Ohio, the Paris of Ohio. That's a good picture, right? That doesn't even have our new building. So Cincinnati has a long history of doing great work around health and health IT and even payment policy. One of the organizations I have the privilege to work with is HealthBridge. You know, HealthBridge was doing health information exchange way before it was cool. 15 years ago, HealthBridge started. And so it was one of the nation's largest, fastest growing, and self-sustaining exchanges in the country. Didn't take a single grant dollar until this high-tech bill passed, when it was too good to pass along. But so it's looked at as one of the few that had a sustainable business model that worked. And so we are growing HealthBridge. I'll talk a little bit more about that in the future here in a few minutes about what we're up to. There's been a long history of measurement, of quality improvement, of all the CMOs of all the health systems working together in Southwest Ohio. It's really an innovation zone, and it's better known in Washington, D.C. and around the country, believe it or not, than in Columbus, as I'm quickly discovering. So the work in Cincinnati is often touted by Jeff Imholt, the CEO of GE, for the whole world. They call it the City Project, where they're trying to replicate the work of Cincinnati and other markets where they have employees. A friend of mine is a CMIO at Merck and for the world, and he said, Craig, our board meeting the other day, one of the board members said, we want to work more with Cincinnati, Ohio. How can we make that happen? It's just, so one other example is if you Google Todd Park, the nation's chief technology officer at the White House, look for his TED Talk on the stage of the Kennedy Center. He gives a talk about Cincinnati, Ohio, and about the work that's been going on there for 15 years, and says it's awesome. One little secret is that the truth of the matter, just since we're all friends, is I wrote the speech for him. So he asked me, he said, Craig, write my TED speech, and I said, all right, but you got to write about something I think is cool. So what have we done in Cincinnati? We've had 3 organizations that are kind of leaders in their little spaces. Mentioned HealthBridge. The Greater Cincinnati Health Council is a Metro membership organization, 30 hospitals plus long-term care, et cetera, doing a lot of work around group purchasing and disaster preparedness, but also really terrific work around performance improvement, quality measurement. A quick example there, Robert Wood Johnson Foundation came to Cincinnati and said, we had tested in 10 hospitals across the country a standardized method to capture race, ethnicity, language data. And we'd like one hospital in Cincinnati to participate in wave 2. And the hospitals in Cincinnati, God bless them, said, we're not going to have one, we're going to all do it. And the Johnson Foundation said, well, that's not our plan, you have to pick one. And they said, well, we're out, we'll do it on our own. And then the Johnson Foundation came back and said, okay, well all right. So flash forward 2 years later, 1,200 frontline hospital receptionists and clerks have been trained on OMB standards. Every IT registration system in Greater Cincinnati has been rewired to capture the OMB REL categories. It's the only community in America, in the whole United States, where race, ethnicity, and language data is captured accurately, consistently across the entire market. So that's just an example of what the Health Council does. Now we're able to do cool stuff like cut cardiac outcomes by race, for example, and do improvement work. Then the Health Collaborative, I'm going to talk a little bit more about that. So the Health Collaborative is kind of like the group that Randy leads here in Cleveland, I'm sure we'll talk about here in a moment, and it is, does a lot of public reporting of data, aggregates claims data and clinical data. This site was, we were recently told it's the most frequently visited public reporting site per capita. I don't know if that'll hang that way for long, but it's designed by P&G experts. We have, and when people visit online, they stay for 3.5 minutes, which is a long time in the web world. And my guess is mostly doctors looking at, which is perfectly fine. And you can sort through that. We have hospital data. We're putting consumer experience data up. We're working on long-term care. So it's a neutral third party. When we started this, we used to think, wouldn't it be cool if P&G would get behind this? And as I mentioned, they designed the website. And then they gave us a loan executive for a year, 30-year brand manager to do consumer testing of the data. Then we thought, wouldn't it be cool if health systems actually use this data because it's better than their own data often. And so now health systems across the market use our data to reward their providers. And then we thought, wouldn't it be cool if health plans actually use this data because it's way better than their data. It's clinical data, and it's full population, big fat denominators. And now United Healthcare preferentially uses this data over their national premium designation program. So it's a great example of how communities can come together and leverage data for improvement. Related, we are one of 6 or 7 what are called qualified entities. This is section 10332 of your Obamacare, if you want to read it tonight. This is about public reporting, transparency, and access to Medicare claims data. The Medicare claims data is a national treasure, but so far only the Dartmouth guys and a few others really could use it. It was like the Washington Monument, but only Elliot Fisher's allowed to go see it. So now it's opened up to the public for entities that have demonstrated their capacity to manage and manipulate these data and keep it safe. There are, I think, 6 or 8 of these now in the country. We're the largest because we'll have full access to Ohio, Indiana, and Kentucky claims data on a regular basis. And we'll be using that to commingle with other administrative claims data to do measurement and public reporting and help providers improve. It was mentioned, lastly, this comprehensive primary care initiative. This is a big deal if you're a primary care guy, if you're excited about primary care like I am, and you think that the future of healthcare in America is based on improving primary care. There are 7 markets in the country that are literally testing the way we're going to reimburse primary care in the future. We're the one with the largest number of payers involved, which brings with it a lot of headache, but we have 8 commercial carriers, Medicaid plus Medicare. And we're driving a very aggressive agenda in 75 practices, about, I forget how many, 300 or 400 primary care physicians. Big employers are supporting this, GE and others. And it's really exciting. Basically, the premise here is pay physician practices better to keep people healthy and out of the hospital. That's the bottom line here. We're quite enthused about it. You know, we started doing at this Health Collaborative patient-centered medical home practice redesign before it was called that. So we were doing this kind of work for a long time. We started with just a couple of cohorts of practices, and then we worked with our big health plans, Anthem, United, and Humana, to differentially pay a group of these providers. This was years ago. And they found that it worked. They were finding that they were getting good, better health, lower cost, and better quality. And so flash forward, we now have more level 3 patient-centered medical home practices, which is the certification deal, per capita in Greater Cincinnati than any market in America, which is just an example, again, of where you can come together, you can start something small, you can grow it, and now we want to participate with you all in helping grow this across the state. We want Ohio to be the medical home capital of America. I'm going to conclude with an announcement. So when I got here, Director Moody asked me, and many others asked me to work with my colleague Dan and try to figure out how to leverage exchange between the 2 exchange organizations in Ohio, OHIP and their CliniSync product, and HealthBridge, us. And so today we are announcing, press release goes out now, that we are HISP to HISP connected. This is Health Internet Service Provider Connected. And so it's a very first step. It's not robust HL7 2.5.1 interface, but it's a very first step. And where's Dan? I'm looking for Dan. Oh, there he is. So we're ready to rock and roll. This is getting us started, and it demonstrates our commitment to make sure that the patients and providers, thank you, in our state are able to move data around to take care of patients better. So what can you do with an exchange? I know this is a research crowd. I'll conclude with this. I was working with the PCORI folks when I was in DC, some in the comparative effectiveness research world. And if you read their work, you'll see a lot of exchange vernacular. Stage 2 meaningful use and a continuity of care record, and the importance of using that to support research in public health. So the opportunity is really quite impressive if you think about a master patient index. Just take that one thing. Dan has an MPI. We have an MPI. We use the IBM Initiate, which is the best-in-class MPI. And so we have about 3 million HealthBridge IDs. And that gives you longitudinality. Irrespective of where a patient goes in Cincinnati, a lot of people don't move from Cincinnati, but they do move hospitals and doctors. So they just bounce around time and again. And so with one singular MPI, you have the opportunity to query these different systems and understand the clinical characteristics and behavior patterns of the provider community and patients over a longer period of time. So we're very excited on our end at HealthBridge to be working with UC, Ohio State, and you guys at CASE on the early thinking about how to leverage some of this and to eventually be able to work with Dan and his group as well to be able to turn some of this data into information. And that's what we're doing at HealthBridge. We're now listening to the data that we historically just moved around with the aim of supporting our providers, our research partners, and ultimately meeting the triple aim objective. Thanks very much.
Thanks, Craig. Our next speaker is Dan Paletti from the Ohio Health Information Partnership. Dan's going to give us an overview of what's going on at CliniSync and the Ohio Health Information Partnership at the state level. Dan is the CEO of the Ohio Health Information Partnership. And without further ado, Dan.
Good morning. Again, my name is Dan Paletti. I'm with the Ohio Health Information Partnership. The partnership is a nonprofit organization that was created back in 2009 to manage some big chunks of high-tech funds coming into the state. Like HealthBridge and Craig, we are helping primary care providers adopt electronic medical records through the Regional Extension Center program. We'll talk a little bit about that, and then our other goal was to set up a health information exchange for areas of the state that didn't have that capability. So I'm going to spend the next 5 or 10 minutes just kind of giving a snapshot of where Ohio is. The good news is this state is doing some pretty incredible things. Even on top of what Craig said, the state as a whole is really moving forward at an incredible pace. And if you think about how incredible that is, Ohio is really a microcosm of the entire country. We have 3 major metropolitan areas that are over 1 million people. We have rural areas that, some of our hospitals still have hitching posts. And for those of you that don't know what that is, it's a place where you tie up horses when you park your buggy and go in for medical care. So we have some of the most sophisticated institutions in the country, and we have some of those most basic small institutions that are really designed to take care of local communities. Trying to get them all on board in the health IT revolution is not an easy task. As a matter of fact, when I started this job 2 years ago, I had a brand new car. I just clicked over 70,000 miles on it driving up here. So trying to get people to work together. The great part is Ohio is a state with Midwestern values. People are really willing to work together, do what's right, and I think some of the things we'll talk about today will really show that. Dean Davis in the beginning talked about where Ohio is. Again, right now we have about 61% of the physicians and 94% of the hospitals that have gone electronic or are significantly on their way. And again, that stands out in front of the rest of the country. And considering where we were before high tech and where we are now, kudos to all of you out there in the audience who have helped the state get there, because it is really, really moving forward. We have out of about 24,000 providers, we don't really know what that exact number is, unfortunately, but we have over 16,000 that have received incentive payments from either Medicaid, and just hats off to the state Medicaid department who's really played an integral role in making all this happen, or from Medicare to help reimburse the providers for adopting health information technology. Now, I do have to point out, even though these are some big numbers, on the bottom there, it's 16,508 and a little over 600,000 or $600 million. That's just a small piece of the amount of money that providers in the state are spending to get where they need to be. So this has helped some providers do some things that they wouldn't have otherwise been able to do. You can't have health information exchange, good solid health information exchange, without electronic medical record adoption. That's why this becomes so important. And that's why having those numbers 61% and 94% so critical, because again, we can't get there unless we get to this first part. The second part is really health information exchange. Again, as I mentioned, we have some of the most sophisticated healthcare systems in the country, many of those up here in Cleveland, who have had health information exchange within their organizations or across organizations that have had the same system for years. The goal here is to enable organizations and providers and those that manage care outside of their organizations across different systems to be able to share information. So it's not just about the providers, the hospitals, the physicians, it's public health, it's commercial labs, it's long-term care. As someone mentioned back here earlier, long-term care is so key to get on board with this, because that's where so much of the money goes. And ultimately, health plans, those that pay for the data, we've got to get them involved. So we are quickly ramping up for that. Where are we? The great news is we have about 70% of the hospitals in the state that have enrolled or are up on either the Health Bridge or the CliniSync platform. That's a little over 70% of them in the state. We think by the end of this year that will be upwards about 85 to 90%. So that is really unheard of when you look across the rest of the country. By the end of the year, Ohio will have more health information exchange ability than any other state in the country. So the opportunities that brings, and I think you've heard, and you'll hear a little bit more, the federal focus and the spotlight on the state, it's pretty exciting, because with that spotlight becomes resources. So what's that mean as far as population? Again, sorry you can't see the numbers down here, but ultimately we have about 70% of the population that is covered or will be covered here by the end of the year in a multi-organizational health information exchange. And again, that's pretty significant. We think that number will greatly rise by the end of the year as well. So we hope that number is going to be up to around 85% by the end of the year. Public health. Health information exchange is really integral to helping public health do what they need to do. And again, we'll talk about the data here in a minute. But right off the bat, the collaboration with public health and the health information exchanges in the state is really around getting some of that information that's so critical to them in a very systematic and efficient way. And then public health, again, Dr. Winslow and his team at the Department of Health is really doing some creative things to make that information more valuable and more useful as far as the research opportunities for that. Our job is to get it to them. Providers is not, enabling providers in itself to exchange information is not all what we need to do. One of the big things that is making a lot of, having a lot of conversation around the country is digital imaging exchange. Being able to share images through health information exchange across providers is extremely difficult. But again, we have some really creative entrepreneurs here in the state that have made some great progress and some ideas about that. And we think, again, this time next year that Ohio will be in the forefront of digital imaging exchange. We have to enable patients, because again, it can't just be about the providers. We're talking about behavior change. We have to enable patient access to their information. Medication history is another key. We've got to make medication history readily available to providers that are treating patients. And then again, registry reporting. So enabling this data for other use in coordination with the state and other researchers, enabling those registries and for those purposes is pretty key as well. I would be remiss as well if I didn't talk about those who pay for care, because again, we can talk about quality all we want, but until we really can prove that we're lowering the cost of that care, we're not going to get the buy-in that we need. So enabling the coordination with the payers is really key, and Ohio, again, is in the forefront of that, and we're pretty excited about where we stand. So let's talk a little bit about the state. I'm not going to spend a lot about some of the things that are going on in the state, because this afternoon you have someone from the state that I believe will talk about a lot of the enterprise work that they're doing, along with the SIM grant that Dr. Winslow talked about earlier and some of the other healthcare transformation efforts that the state is working on. Their ability to receive information, exchange information within state agencies, and accept information from outside agencies is going to be much more robust, and we're very excited about that. The state did pass a law last summer that talks about consent and aligning Ohio more with HIPAA. Again, basically that rule is if a provider is moving information from provider to provider, they do not need the consent, because that's inferred in the referral or the order or what have you. However, if the data is made available for query and such like a community health record, the patient education is required. You have to inform that patient that is going to be available for query for their treatment, and they do have an option to say, no, I don't want to do that. With our policy, again, CliniSync is just the portion of the HIEs that we're dealing with. We have gone down for query information that patient consent will be required, except in emergency room situations, and patient consent can be obtained by any provider, and that can be shared among all providers. But again, we think it's critical to ensure patient trust in this, especially early on, that they have some oversight over their information, because in reality it is their information, even though it is being maintained by the providers that are caring for them. I will skip over that. Again, I think what's key here is that the assets being built in the state, you heard a little bit about what Craig's doing down in Cincinnati. You'll hear a little bit about what is going on elsewhere in the state. And the important piece here is that we are well on our way. Ohio is going to be in the forefront. The ability for this state to work together is huge. And again, I'm very excited about being able to stand up here hopefully a year from now and even expand on the great things that's going on in the state. So with that, Brian, I'm all finished. Thank you.
Thanks, Dan. We're going to move now into the local perspective on HIEs. And to do that, we've actually split the local perspective into an urban perspective and a rural perspective. For the urban perspective, we're going to have Randy Siebel. He is the director of Better Health Greater Cleveland and has been so since 2008, since it was founded. He's also the director of the Case Western Reserve University Metro Health System Center for Health Research and Policy, and a professor of medicine, epidemiology, and biostatistics at Case. Let's welcome Randy.
Thanks, Brian. Do we have, what do we do here? There you go. So thanks to Brian for the clever title on this slide. Where am I going? How about this? Oh. Slideshow. All right, good. So this is the, thank you. So we're talking about health information exchange from the computer to my brain. Anyway, thanks very much for the opportunity to speak today. I will talk a little bit about successes, but I also promised Brian that I would leave time, and there may be time in the Q&A, to talk about challenges in health information exchange as well. I am represented as being Better Health Greater Cleveland director, and our vision is to help make Northeast Ohio a healthier place to live and a better place to do business. Healthier place to live is what we've been working on for the most part, and a little bit of the work that we've been doing recently has focused on costs. And the mission here is basically for Better Health Greater Cleveland to provide a safe space where healthcare collaboration can come together. Dan's comments to the contrary notwithstanding, there is some competition here, so it's a safe space for competitors to collaborate and a safe space for collaborators to compete. And so that is really what Better Health Greater Cleveland is about. One of our many mottos is Deming's motto, which is "In God we trust, all others must bring data." This is the slide, I think, that the area up in blue Dan had is called the non-gap area. I don't know what that was, but anyway, that's Lake Erie, and all of these gold stars are NCQA, patient-centered medical home, level 3 recognized patient-centered medical homes. Those all have been supported by Better Health Greater Cleveland. There are 70 practices altogether in Better Health Greater Cleveland, about 13 hospitals that are partner members, and Craig's comments to the contrary notwithstanding, all of the hospitals here are in fact doing REL. Race, ethnicity, language preference, it's really quite remarkable. So the electronic health records have really helped us to provide better care and accelerate improvement. We were pleased to be able to publish an article in the New England Journal a couple of years ago, year and a half ago, that basically showed the differences between achievement in patients who were cared for in systems with electronic health records, both achievement in care and achievement in outcomes and improvement over time. So we were able to document that with sufficient clarity that Farzad Mostashari, I think Craig's boss until very recently, where you have no bosses, right? And anyway, he came to Cleveland and basically walked through Metro Health and said, "How do you do this? How did you do this?" And we were pleased to have him present. So this is not in the sense that Dan Paoletti talked about health information exchange that we're using, but it's patient-level data that is provided from all the different partner systems in a de-identified way and securely shared with our data center, for whom the director here is Tom Love. And we have decided that we would use common conditions. Diabetes, high blood pressure, heart failure are the conditions that we've been measuring. We have inclusion and exclusion criteria. We have numerators and denominators for all the measures, for all the standards that we've adopted, which are basically nationally endorsed and locally vetted standards. We have non-clinical data that is obtained directly from the medical records on insurance, Medicare, Medicaid, commercial, and uninsured, race and ethnicity, sex, and language preference. So we're all measuring language preference in the outpatient setting as well as on the inpatient setting. And SES data, or socioeconomic status data, obtained indirectly at the patient level using geocoded links essentially to the census, what is now the American Community Survey, to estimate at a patient level the household income of folks in the neighborhoods where our patients live and the educational attainment levels of the neighborhoods in which our patients live. So we have clinical data, we have non-clinical sort of administrative data, and then we have socioeconomic data that we link from the census. What we've done then, so these are, all of these bars here are different practices. All of the red bars are practices from one particular place. from one particular healthcare system. This is the change in the percentage of African American patients with blood pressures of less than 140/90 between 2009 and 2011. And for us, we've used the data to identify what we call bright spots. We interrogate the bright spots, say, do you know what you did? Oftentimes they don't, but in fact they do know what they're doing. And so we're able to get them to essentially articulate the best practices that have enabled them to do the change in the performance that they've made, and they then are sharing best practices throughout the region. And this is who they share it with. This is the safe space for competitors to collaborate and for collaborators to compete. And these are all of this is 200 plus people who come twice a year to a day-long learning collaborative. This was March 13th of this year. And so here what we're showing is that we're as of 2011, then we found that while we're not nearly where we'd like to be, 48% of the African Americans in Northeast Ohio who are reporting in Better Health Greater Cleveland, which is about 130,000 patients with high blood pressure, have their blood pressure in diabetes under control, and we're going to be sharing those best practices throughout the region. Overall, the current level of achievement in hypertension patients under control is 70% as compared to, Tom, what, 47% according to the most recent data from the CDC nationwide. So 70% in the region. So, so we've done, Dan said we could talk about quality all we want. That's what I'd really like to talk about. But we also were encouraged to talk a little bit about cost. And so not having the statewide HIE, we basically had to go to another data set that Dan had created when he was at the Ohio Hospital Association, which has been a multi-payer data set for hospitalizations across the state, uninsured Medicaid, commercial, Medicare patients. And we basically said, how are we in Cuyahoga County doing on those conditions where primary care should result in reduced hospitalizations for complications of those problems, cardiovascular conditions in particular. And so using the Ohio Hospital Association database, looking at 18 hospitals, not just the 10 that were reporting in Better Health through this period of time, we looked at hospitalizations, potentially avoidable hospitalizations for diabetes, high blood pressure, and cardiovascular disease prevention quality indicator diagnoses. PQIs is what they're called. And so basically these are averted hospitalizations over this 3 years. Left is 2009, 2010, 2011, and overall basically averting 2,600 hospitalizations for these cardiovascular conditions in Cuyahoga County. And this is compared to Hamilton, to Franklin, to Summit, to Lucas County, I guess that's Toledo, right, and Montgomery County. And this is a model which basically estimates the number of averted hospitalizations during this period of reporting. Now, this is more, what I'd like to move to now a little bit is sort of real health information exchange as we would like it to be, and perhaps close to what we'd like it to be. So the issue here is we've had health information exchange in Northeast Ohio and Cuyahoga County among the Epic-based vendor sites within the region since late 2010. So Care Everywhere is the Epic functionality that enables us to look into records real time at other unaligned systems where we're able to see basically everything that occurred in that patient's care. So it's comprehensive, it's real time. We pull, which is to say we aren't pushing data to another unaligned site. We are pulling data from that site if that patient has been seen and consented in an opt-in way for each encounter. Now, Dan says we don't have to do that, and I hope we won't have to do that forever consent each encounter into the future. So this little project that I'll show you 2 slides from relates to Metro and the 9 hospitals of the Cleveland Clinic. So Care Everywhere was rolled out on November 1st, 2010. David, is that right? Yes. Yes. And so the question is, how was HIE used? So this is sort of an urban setting. How is HIE used by safety net docs like me, like David Kalber? For whom was it used? And what did the metro providers on a survey that was done by Rehan Wahid? Where are you, Rehan? Good, thank you. What were the Metro's providers' views of the value of health information exchange? The use, the first thing is use. So by comparison to the ED, so ref here means referent in a multivariate logistic regression model, okay? So the referent here is emergency department, uninsured, white, and per additional comorbidity. So as compared to patients seen in the emergency department, there were fewer exchanges requested, polls made in subspecialty clinics than in primary care, and certainly then compared to the emergency department. Medicare and Medicaid were most often, patients who had Medicare or Medicaid were most often sought. Commercial insurance, interestingly, which we could talk about, had less pulls of their data than did the uninsured or Medicare or Medicaid. African Americans, older patients, women had more pulls of information than did whites, and there was a 30% higher odds of having a pull made per additional comorbid illness. So it's what you'd sort of think. Older patients with more comorbidities basically are more likely to have information in other silos in the region, and those are the ones who are more likely to have the data pulled. We asked, and Rehan did this survey, we asked the providers, and this wasn't on a patient level, this was overall their exposures to health information exchange. What do you think about do you agree that HIE does the following? Now, you can't read this, I'm sorry about that, but 93% agreed or strongly agreed that it provided more efficient care. 85% said it helped save time. 15%, mostly from the emergency department, said it prevented an unnecessary hospitalization. 84% said that decreased laboratory test use, redundant tests, just as one might expect. And 74% said that it reduced redundant imaging tests, and 82% said that it improved patient care in other ways. So it was a pretty impressive, actually surprising to me, response to the survey. So in summary, sharing trusted and timely electronic health record data and best practices can accelerate improvement, reduce avoidable costs, and identify disparities and document changes in population health. In 2 weeks, we're reporting on 145,000 people in Northeast Ohio and the care that they're receiving. Real-time HIE is perceived by safety net providers at Metro a year and a half ago to reduce redundant laboratory and imaging tests and to improve the efficiency of care. So I think I will stop at that point and take questions in a little bit. Brian?
Thank you, Dr. Siebel. We're going to move on to our final presenter for the panel, and the topic is going to be rural perspectives on HIEs. We're fortunate to have Brian Phillips from Ohio University. He currently teaches healthcare administration and clinical informatics down at OU. Formerly, he served as the Chief of Medical Informatics and the Director of the Southeast Ohio Regional Extension Center. So let's welcome Mr. Phillips. Thank you.
I realize I'm in an enviable position of being the speaker that stands between you and lunch. Okay, so if I move through some slides quickly, I'm going to be sensitive to our time. Greetings from southeastern Ohio, rural southeastern Ohio. For those of you who've been to southeastern Ohio, you know it's an absolutely beautiful part of the state. And from Ohio University's perspective, I'm biased. I think it's one of the more beautiful campuses in Ohio. As I was driving up here from Athens last night, I knew that it was summertime. I knew that we were through the graduation and people were thinking about summer vacations, and the Ohio unofficial flower was in bloom, the wonderful orange beryl that is all over the state. So we know it's summertime, and I began to think about, are we there yet? Okay, so those of you who are parents, okay, or were kids, and were put in a car for many hours on summer vacation, know exactly what this is like. So I'm just going to talk really briefly about the journey that we've kind of come through and kind of where we're going. I had an opportunity to see Dr. Brayler the first time, Director of Office of National Health Coordinator at HIMSS in 2004, where I met two people from this dynamic and emerging group from my hometown called Health Bridge. Okay, and I've had a significant amount of help over the years in our development from them, and I really appreciate that. It was at that time we had received a grant from the Integrated Advanced Information Management System from the NIH to do an initial analysis, to kind of look at, from a health administration standpoint, what was going to be required in developing and moving from paper records to electronic records. As a part of that, we did a 400-patient phone survey and getting feedback on what patients felt about having their availability of their health information in an electronic form and being shared. We did focus groups. Interesting, one of the focus groups, we had a young mother that mentioned to us that she felt that her Walmart had better technology than her healthcare system. It was absolutely true. If you think about it, when you buy something, there's a whole set of chain of information, inventory control that goes on, something we just don't have in a comprehensive way for healthcare. So that was really exciting to us to kind of get an idea and get our feet wet. This is not unusual for many of our providers. This is a paper record, a repository in one of our critical access hospitals. This patient file is actually from behavioral health, and as you can see, I have highlighted on the label, it was chart 12 of 12. Okay, so we know we're not keeping this information for any kind of a reasonable health care, and the need really became just popped out of the fact that we need a better way to keep from keeping this data just for legal requirements, and it really needs to be incorporated into how we can help patients and providing health care. It was at that time that we began to develop the RIO. You all remember the RIOs. The Appalachian Health Information Exchange, where we basically brought all the hospitals and clinical ambulatory care centers within the region together and said, what are we going to do about this? We know it's coming. We know that we need to organize, and we've always felt very strongly at Ohio University that partnership is the best way to deal with the limited resources that we have in these rural and underserved areas. At that time, we also received a pilot project from the Appalachian Regional Commission, and we actually built our own electronic data interchange. We're able to move records and exchange those records in a pilot situation. So we really got our hands on moving information and really provided us some good information and an ability to move into the next step, which was the Ohio Health Information Partnership and being able to direct the rec in that area. We were originally allotted 404 slots. We were the first rec to reach its allotment because, again, we had forged those partnerships. We were familiar with the healthcare providers and the institutions within our area. OHIP was extremely gracious, as well as the other recs, in being able to pull additional allotments together for us, because we had waiting lists. We had more physicians that again, wanted to participate, so we were able to add an additional 100 contracts. To date, as of yesterday, because I called over to the rec office, and currently we're at 100% with our milestone 1. We're at milestone 2, almost 92%, so 462 out of our 505, and we've moved almost a third of our priority primary care physicians into milestone 3. So we're getting there, okay? We're putting the plumbing in, we're getting the data to a point. I just want to highlight that Southern Ohio Medical Center, part of CliniSync and the Ohio Health Information Partnership, doing amazing things. And again, we have short time here, but I just want to, again, highlight the fact that we have hospitals in the southeastern Ohio area, in the rural Appalachian region, that are just doing outstanding things with health information exchange. However, as you notice and go east, there aren't many pins in southeastern Ohio of participants in health information exchange. And again, we're hoping, again, to continue to build infrastructure and to make sure that everybody has an opportunity to participate in this outstanding statewide exchange. But we have some challenges in southeastern Ohio that we share with other rural areas. As we know, as we move through the meaningful use, we're getting there with EHR. We're moving a little slower in health information exchange. We are particularly interested in the element of patient empowerment. We know that we're going to see about 30 million new insured Americans, and that may change even more as they're moving through immigration reform. So again, somewhere between 124,000, 159,000 physician shortage is being identified. That's going to impact significantly in the rural underserved areas as we have to compete for healthcare professionals, as well as the infrastructure issues that we have, both physical infrastructure, basic internet services, again, are still not a given, 4G, 3G, what we have is G, which is, gee, we wish we had more infrastructure, okay? So this is still building, okay, and it's extremely important. Geographic isolation, how do you deal with the data sets that identify, again, the high incidence of obesity when you have people living in food deserts, okay? So if you don't know what that is, people that just don't have access to grocery stores and good food, and basically getting nutritional supplements, getting their food from the local convenience store. And Yahoo and Slim Jims is not the way to beat nutrition in the rural and underserved areas. So we've got to deal with some of these other structural issues as well as the data elements. Again, physician shortage areas, high rates of chronic disease, aging population higher than in other areas, and again, just the socioeconomic issues. We have to take a multidisciplinary approach, a multi-area approach to these ills in these rural underserved areas. The data won't just get us there. We've got to be able to find other ways to connect the data, to connect the information, to have real changes in order to give people an opportunity to be healthy and to want to be healthy. So we're not there yet, okay? But we're getting closer, okay? We're feeling like we're moving through. And again, that's through building partnerships, again, something that we've always been able to do well, developing leaders, and a multidisciplinary research approach. So building partnerships, we have the Appalachian Rural Health Institute, again, fostering interprofessional research, community outreach, education, again, scholarly activities. Okay, so there's the academic piece that's extremely important. Building workforce. Okay, so we have the Heritage College of Osteopathic Medicine and its expansion, again, expanding into to our Columbus campus, building partnerships here in Cleveland, developing again through the medical home, integrating that into our curriculum to make sure that the physicians that, again, that we graduate out of Ohio University are prepared for this new paradigm in dealing with this data. the College of Health Sciences and Profession, the college that I'm currently a faculty member in. Again, multidisciplinary collaboration. We're developing both a clinical informatics certificate program, again directed for professionals already in the workforce, basically your chief information officers, nursing staff, other people, again, who are going to be extremely important to get up to date on what we're doing with clinical informatics and health information exchange, as well as developing master's program. Just want to briefly mention the Appalachian Translational Research Network. Again, a number of partners there. There's a website, so if you'd like to Google up the Appalachian Translational Research Network, or ATRN. Again, lots of good work being there. Again, foster that community engagement and the outreach within the Ohio, Kentucky, and West Virginia area. This is probably the slide that I most want to focus on. It's the last slide, and of interest of mine as far as the development of research. We think about our traditional data information knowledge triangle, and we've all seen that. We're really working at that data level in southeastern Ohio, again, working with OHIP, working with the RECs, and working with physicians and our hospitals. We're getting there. We're getting the basic plumbing in. Earlier talked about information, and again, that information is exchanging. Well, we're really concentrating in a number of areas of our particular research and areas of focus is how do we get to that knowledge piece? How do we really think about those modifiable risk factors as we look at heart disease, especially with obesity and its influence on our growing epidemic in southeastern Ohio of type 2 diabetes? So again, being able to think about not only physician and healthcare dashboards that give us quick information, that have us be able to look at the healthcare indicators, but how are we going to empower the patient? Okay, where is the patient as far as getting that information and being able to want to be healthy, and then giving them the opportunity and the infrastructure in order to be able to allow them to reach that level of health. So those are all things that we're very much interested in, again, looking at the National eHealth Collaborative. And again, that partnership and that supporting that e-community of healthcare and dealing with those issues in public health, we're extremely interested in. And we look forward to sharing the journey with all of you and coming up with some solutions to these big problems that we all face. So thank you.
Thanks, Brian, and thanks to all of our panelists. We had some really good talks this morning, so let's give a round of applause to everybody. So now we're going to open up the floor to questions. We have about 10 minutes before lunch, and the way this is going to work is raise your hand, I'll point at you, and somebody will bring you a mic. So let's... It is bright, and can somebody in the back turn off the screen? I don't think we need it on for this. Perfect. Thank you. Questions? Yes. And let's wait for the mic so everybody can hear.
Hi. I'm hoping someone can help me understand the relationship between the National Health Exchange, like Healthy Way, that Medicare, Social Security Administration are members of, Veterans Administration, and the Ohio State Exchange.
I actually missed the verb of that question. I'm sorry. I was goofing around up here. Can you
repeat the question?
Very beginning part.
So we're well known as the National Health Exchange, Healthy Way, that Medicare, the VA, and the Social Security Administration belong to.
Right.
And we're wondering, or I'm wondering, what is that relationship between that exchange and the state health exchanges?
Okay. I'll take a stab and pass it out to you. All right. So first of all, good news, bad news is that exchange is being differentiated. So there's going to be more and more ways. Think about you used to communicate with your mom by writing her a letter. Now you could tweet her, or Snapchat her, Facebook her, all that stuff. So that's the same is going to be true in health information exchange based on use case. HealthBridge was one of the founding signatures of the nationwide health information network, which is now Healthy Way, and it is primarily driven by the federal sector. Like, for example, we do this thing with the disability folks, so we can query and pull data out of a record and send electronically for disability determination. But so that'll be the major vehicle for big, robust exchange. So we, for example, are doing that now in Kentucky, is connecting through New Hen to connect to the. So I think that's. I'll actually let Dan kind of explain his plan there.
Yeah, no, it's a really good question, and I wish I could give you a better answer other than we are keeping a very close eye and trying to align ourselves to what they're doing. The problem is that it's not moving to a point where we can make it functional. And the reason Ohio's been so successful is we've really focused on what can we do that's going to bring results and return on investments and success around patient care. And when you look at the care that's provided in Ohio, 95% of the care is provided within our boundaries. The balance of that care, for the most part, goes to surrounding states, and then we have to go outward. So we are working with, through HealthBridge. We have Kentucky, we'll have Indiana. We just signed an agreement with Michigan. We've reached out to West Virginia and Pennsylvania. So we're not waiting for Healthy Way. We're just going to do it ourselves. When they come out with a solution that we need to do, we will do that as well. But we want to be in control of our own destiny, I guess is the best way to say it. Now, the VA is a very good question. We are working with the VA directly to try to solve that problem again without trying to go through the national network. So that's our plan today.
Thank you. Other questions? All right, well, I'm going to ask a question. Oh, we have one? I'm sorry.
I'm Jody Mitchell, and I'm the Health Policy Program Officer at Mount Sinai Healthcare Foundation. And I think I only saw on one of the slides, and forgive me if I missed it, where patient empowerment was actually referenced. And I think I'm interested in knowing from the panelists how so much of the driven change right now is process-oriented through institutions and technology, but how can we leverage that and really start to educate patients and consumers, because we can do all the changes and transformation we want, but if we don't have behavioral change, we don't get the outcomes. So I'm interested in the perspective of the panelists.
Good question. Well, a good thing, I'm just jumping in here, boys. The good thing is that Stage 2 meaningful use pushes, I can't see you. No, you use it. Consumer-mediated exchange, right? So it requires providers to make data available to patients, not in just some like text file, but actually consumable and parsable. So that's good. So Stage 2 is going to push that. The Blue Button Initiative you might have heard about, which is this notion started in the VA and is now run by ONC, is this notion that consumers should have access to any data that is about them. And that there's you can look it up, the Blue Button is really a concept and a kind of a wave of enthusiasm, and then also some actual technology. The actual technology is for the veterans and increasingly CMS to patients to be able to download that data to a personal health record or to an iPhone app or whatever. But the concept is even more powerful than the actual technology, and that is that anybody who is a data steward should have a blue button, irrespective of if you're a payer, state government, Medicare, physician practice, a blue button. The technology is dependent upon what your job is and your role is, but this notion of a blue button is even more powerful, that patients own the data and they should have access to it. And I was just in DC this week with a bunch of startup companies. There's all kind of cool stuff coming out to leverage the blue button data. So I'm excited about it.
I have very little to add to that, Jody. From a medical point of view, I think health care and test results and things of that sort is just a small part of the picture, is my view. We've talked with Karen Butler and other folks in the public health arena. I mean, this is and with Ted, I mean, if you look at the social determinants of health and what essentially affects, what are modifiable factors that can affect quality and quantity of life, 90% of that is outside the healthcare system. So hurrah for everything we're doing in the engagement of people having their own health data, which is definitely happening. But in addition, I think to the extent that we can better coordinate and collaborate with our public health partners and with health forces in the communities, I think that would take us a lot farther.
And I would just add too that the policy that's in place for the participants that work with us is we are going to empower the providers to be able to access the patient information that's available through a health information exchange, and then enable the providers through their patient portal, if they don't have one, supply one for them. We think it's very key, though, that the relationship be between the provider and the patient, not between the health information exchange and our situation. And we're really, hopefully Ohio's solution is patient-centered medical home in this whole concept about really getting the provider and the patient together and helping to drive those changes. So again, I think what I would ask you all to consider just for a second, the analogy that I like to use is just close your eyes and picture out on the Serengeti for a moment. And all the different animals are coming to the watering hole. And that's kind of what we've got here in the state. We've got all these people that are saying, you know what, now's the time, we're all willing to come together and start to work together, but everybody's very nervous. And if we don't keep that trust, especially with the patients, and build that ability that everybody is comfortable, they're going to scatter. I mean, the first sign of trouble. So we have to take this very carefully. And again, we think the best way to keep the patients engaged is through the provider. So that's.
Can I follow up on that?
Yep.
Sure. Because I think the important thing too is that the patients understand what information they should have, not just what's in their record, but their personal health record, and what they should know about themselves. We have a health literacy problem, and so the more we can educate what information they should know, have it with them at all times to help the system serve them better, is probably another key.
Sure.
And I'd like to add to that. There are other areas, again, information, databases, data sources that we can incorporate in the healthcare consumer and being more preventive. Again, coming from the health side, we have the health information, but we need to be able to empower families. We need to be able to empower individuals. If we just look at nutrition, what are your nutrition numbers? I mean, we have barcode, we have nutritional information. So when you go to the grocery stores, why don't we have a health report card on the data of the foods that we're buying? To be able to empower people and say, well, how much sodium is your family eating based on your groceries and the things like that? So we've got a whole other set of I think, data areas in the consumer side to be thinking about. And resources to be able to empower patients to not only be engaged but be accountable, okay, for their preventive health care.
Thank you. I think this. Are you asking a question as well? Or? No. Okay.
Gave me the microphone.
Okay, perfect. Thank you. Sorry. This is our final question, by the way, before lunch. So
primarily directed to Randy, but anyone can weigh in on it. I am, as one of those public health people, I'm thrilled to see the integration of neighborhood or area level social demographics into your process. Two questions. First is, what have you thought about, because I'm sure you have thought about expanding that from just income and education to other social demographics like food deserts, this just came up. What have you thought about including beyond those two measures? And number two, are there any thoughts about mechanisms to make that information available to the clinician in an automated fashion as they see the patient, so that they have a sense of the area level social determinants of health that their patients face?
In answer to the last question, yes. Yes. I mean, I think it's a terrific idea. Sherry Boland is going to prove it's possible and do good things with it. With regard to the census or the ACS, you can pull down anything you want. And so what we're doing actually is this is a very federated approach. We basically provide to them, correct me if I'm wrong, Doug, but we send them we send all of our partners a program which enables them to link the address of their patient and the geocode of that patient to the census, which then enables them to pull down whatever we wanted. And we agreed as a group that we would do things that we thought were most predictive of bad health outcome. So we said income and educational attainment. There were lots of other things, and we could, going forward, do more. We thought we would do less, just as less burden to our partners, but I think that what you're saying is right. And yes, I would think that we can geocode all of those things that you know the PERCHIN, the Prevention Research Center, is doing, and essentially pull that into the E.M.R. and deliver it to the provider at the time a patient from a particular neighborhood is being seen. And yes, right.
Thank you. This concludes the panel session. And I believe it's lunchtime, so back here I believe at 1 o'clock.